So burns from childhood are what changes the DNA in the skin cells, which leads to melanoma. We know that for a fact. We also know for a fact that because the ozone layer is much thinner, that the sun is much different now than it was 10 years ago, 20 years ago, 40 years ago. So every single one of us should be using sunscreen winter, summer, fall, spring, all year round. And for those of you who are light-haired, light-eyed, fair-skinned, and freckled, you should be covering up on top of that. So, what is this? So we talked about storage of flammables. Oh, we didn't talk about stop, drop, and rolls. Stop, drop, and roll stop, drop, and roll is what they say you should do if your body is on fire, or if somebody else's body is on fire. You should give them very clear directions, which I can't even think about. I mean, I can't even think about having presence of mind if my body was on fire on some part of me, to stop what I was doing, get down on the ground, and roll. Because when you roll on top of the fire, it doesn't allow oxygen to get to it, and lack of oxygen puts out a fire, right? We've been hearing that since the big fire in the city, right? Close the doors, close the doors, close the doors. Well, this is how you close the door on your body. You stop, you drop, and you roll. The evacuation plan, which I talked about. When we did the evacuation plan with my oldest daughter, she was the first one. We had done many since then. But she wanted to meet on the front lawn. I said to her, I don't think if the house is on fire, we should be on the front lawn. And I said, why don't we go across the street to our neighbors? And she said to me, she was like 5, she said to me, I'm not allowed to cross the street. I said to her, I promise if the house is on fire, I will not punish you for going across the street so that you are not burned in the fire. So then she was like, oh, I can cross the street? I'm like, only if there's a fire. No, only if there's a fire. That's the only time you can cross that street. So you need an evacuation plan. And if possible, you should have 2 choices. Front door, back door, front door, window. If it's a window, preferably you're not jumping, you have one of those ladders. They're a lot of money, but you throw them out, they're on chains, they roll up. You throw them out, they hook onto the windowsill, you throw them out the window and you can climb down. And I think they're like up to 3 stories, I think is how far they can get them. And then home first aid, that's actually one of my favorite things. Anyone have any home first aid stories? Or methods that you use for a burn, like leftover from grandma or great grandma?
Toothpaste.
Toothpaste, I get that one every year, I don't understand it. Because if I think about that, most toothpastes have mint, and you put mint on an open wound, I think it would burn like hell. I could be wrong.
It cools it, I don't know why.
It does, interesting. We should investigate that. Honey? Honey is not a bad thing. Why is honey not a bad thing? It's actually antimicrobial, like naturally antimicrobial. So honey is not necessarily a bad thing to do. Anything else?
Eggs.
Eggs. Eggs. Never heard eggs. This is a new one. I like new ones. Do we know why?
No, but my.
The whole egg, the white, the yolk, what?
The whole egg. You just crack it on the.
You crack it on the burn.
On the burn.
Well, let's think about that. Logically, it's cold, it's coming from a refrigerator, so it's cool. And the egg yolk it's probably a lot of protein, so it can't really hurt anything. It's gotta be gooey and icky though, I would think. But, I don't know that one. Anyone have any other one? I've heard, what? Milk, probably same thing, it's cold, right? So I've heard potatoes, sliced potatoes, that's not a bad one either. Again, it's the coolness. I've heard yogurt, which is similar to milk. Yogurt has the extra added plus of having active cultures, so maybe that would help. No one in this group said oil or butter, which I hear almost every semester. and we do not wanna do, ever, because that actually traps the heat, and when it traps the heat, it expands the burn. So no oil, no butter, that's why we don't use baby oil out in the sun anymore. In my day, like a million years ago, when we would go to the beach, we would like take Johnson & Johnson baby oil in the summer was always sold out, because you would slather yourself in Johnson & Johnson baby oil and sit out in the sun and bake. Really dumb. Now I sit under an umbrella, no allowed to have them. So what do we do for home first aid? Cool water, not ice cold, not ice. Ice will actually make the burn bigger as well. But cool or tepid water, so tepid means like room temperature. You can wash it with just a gentle soap. Pat it dry. And bandages are optional. Bandages, for me, have to do with where they are. I will almost always bandage a hand if it's bad, because you use it a lot, so it's gonna have a lot of other, influences besides just the burn. I will almost always, wrap a foot if a foot is burned. But unless I'm in the hospital and I've got a specific order, it really has to depend on what the patient does, what they're going to be doing. Like if they're going back to work and they work in a hospital, let's say, like one of you gets burned and you go to work the next day, you should have that thing covered, because we don't want germs from patients and other people getting in your wound. That would be bad. If you were a teacher, you would probably not want to be around snot-nosed kids with an open burn. Also, not good. So, dressings are kind of situational, but cool water, mild soap, pat it dry, and then make a decision as to whether or not you're gonna cover it. If there's a blister, we do not break the blister, we let it bake. If it breaks on its own, it breaks on its own, but, we generally do not, advocate for breaking a blister. The other thing you can buy, and I wish I could tell you why they work, because I don't know why they work, but they work. And I now keep them in my house at all times. We had a student a few years ago whose husband worked for PSE&G, and she said to me, they keep in their first aid packs, they're called colloidal gel dressing. And she brought one in to show us. It was like this big, it was like gigantic, because I guess they get bigger burns. But you could buy them anywhere, CVS, the grocery store, whatever brand, whatever, and they come in different sizes. And if I had not seen it with my own eyes, I would not have believed it, because I burned my daughter's hands not too long ago. We were on vacation, and I was grilling, and I had a summer house that we rented, it wasn't ours, and they only had metal pans, and I had the metal pan next to the grill, and I didn't think that close. And I touched the front, because I handed it to her, I touched the front of the bowl, and when I handed it to her, she screamed, so she took it with both hands. It was a giant bowl of chicken, of course, in olive oil. She screamed, she threw it in the air. There was olive oil all over the walls of this rented house that I now had to clean, and the floor, and the rug, and everything else. Shouldn't have been a rug in a summer house anyway, but what are we gonna do? And I had burned the palms of both hands by handing her that. So I sent, and she was old, she's an adult. I stuck her hands under water. I sent the other kid to the drugstore to get these burn things. I figured, wanna try it? And I cut them, and I wrapped each finger, and then I wrapped each finger with gauze, and then I put one on each palm. So she looked like a mummy, the way I had her wrapped. But by the next morning, she was already blistering by the time she came back with the pads. By the next morning, it was gone. She had no more blisters, it was red, it was painful, we had to watch it for a couple of days, but it never really blistered again, it never, it didn't scar, it didn't do, I was shocked. Because I had taken care of burns before in my own house, that maybe were not quite as severe, and I never had that kind of resolve, so I keep them in my house at all times. In many sizes, mind you, because the other one, that same vacation, says to me, oh, I don't need sunscreen, I'm dark enough, I can go out, and so she went out for like 5 hours, and the next morning, her entire chest was blistered. We put the pads, she was like padded up, because they only had little ones, they were like 2x3s, I had them all, next morning, gone. It's like a miracle. So, I can't tell you how they work, but I keep them in my house, so I pass it on. But if you don't have those, again, just a clean dressing, tepid water, mild soap, like you don't wanna be washing them with, dial soap, that's probably not good. Okay, so we talked about these already, the intensity, the duration. We didn't really talk about type of tissue too much, we kinda jumped over that, so, don't worry about it. So the intensity is how strong or how strong the causative factor is of the burn. So if you stick your finger in a socket and it's a 120 socket, you get 120 volts. If you stick your finger by accident and it's 240, it's 240 volts. You're gonna, the intensity is different. And if you're a PSE&G guy, they're thousands of volts. So different intensity. Duration is how long, we already talked about that. And the type of tissue makes a difference. And we talked a little bit, we talked about the mucous membranes, that's really, so we have skin and we have mucous membranes. Those are two really types of tissues that we're talking about. What do we know about mucous membranes? Anything? What makes a mucous membrane? They're very moist, and if they're very moist, what does that usually mean?
They can dry out.
They can dry out, what else does it mean? How do they get moist? They have a lot of blood vessels. Mucous membranes have a ton of blood vessels. So, if there's going to be damage to mucous membranes, you're going to have a lot of swelling. And if you think about where our mucous membranes are, they're up they're on our eyes, right? Our conjunctiva in our mouth, and all the way down, right? So what happens here goes all the way down. Our GI tract is mucous membrane, which for this instance isn't too severe. Our perineal area is also mucous membrane. And the perineal area has two other complicating factors. Number one, it's a dirty area of the body because of urine and stool, so the risk of bacteria is much higher. And because of the other function of the perineal area, which is sexual contact, there's a lot of nerve endings. Because if there weren't nerve endings, we'd have no pleasure from sex. So there's going to be a gigantic problem with pain if the perineal area is involved. And infection. Those are the two things for the mucous membranes of the perineal area. The thing about the mucous membranes of the nasal and oral pharynx and the GI tract is going to be swelling. So it's really a medical emergency if you have nasopharynx, oral pharynx that's burned. You have the risk of cutting off their breathing because there's so much swelling. It closes the trachea, and it either closes it from the top or it closes it from swelling around it. And then you have a respiratory arrest. So anytime there's any tissue involved with the face, we have to worry about the swelling and then what that means down the line for this patient. The other thing on type of tissue, it's not really different tissue, but the palms of the hands, the soles of the feet, those areas are not areas that are exposed to the outside world that much, right? The top of our hands more, they're rougher, our arms are more exposed. But when you're talking about, it's not the type of tissue, because it's regular skin, but it's where it is on the skin. So palms of the hands, soles of the feet are problems. The other, just went right out of my head right now. The other areas that are problematic are cartilage. What's cartilage on our body? Well, I know our joints. Ears, nose, and our joints. So, what do we know about cartilage? Anything?
They're not very vascular.
Not vascular, the total opposite of mucous membranes. They are not vascular, and because they're not vascular, they don't heal well. So, if you see pictures of patients who have facial burns, they are often missing pieces of their nose, they're missing the pinna of their ear. If their bodies are burned, and it includes a joint, a lot of times, if it's gone as deep as the cartilage does not repair itself well. So it's going to interfere with activities of daily living and all those kinds of things. So this is what we're talking about when we talk about types of tissue and how it's going to impact the long-term survival and how well they survive for these patients. When I worked at Sloan Kettering as a brand new nurse, right across the street was Cornell, which is now Columbia Cornell, or Cornell Columbia, I don't know, somebody bought somebody. But at Cornell is the burn center for New York City. So all the firemen go to Cornell. And if they're in a fire, they'll take them someplace close to stabilize them, and then off they go to Cornell. And I was walking around outside one day getting lunch, and I saw someone I went to high school with. I was like, oh, what are you doing here? She was, I'm a nurse. I said, I'm a nurse. She said, where do you work? She said, are you at Cornell? I said, no. I said, I'm at Sloan Kettering. She goes, oh, I'm at Cornell. I'm in the burn center. She said, let's have lunch one day. I was like, okay, I can have lunch. I was like, that's nice. So she said, come up and, meet me, because sometimes it's hard for me to get off. We'll just eat upstairs. I was like, okay. So we made a date, and off I went, and I get up to the floor, and the door opens, and all I could smell was burning flesh. I got back into the elevator. I went back downstairs. I used the house phone, and I said, I can't eat up there. Nothing usually affects my appetite, but I could not. It was so overpowering. She says to me, what, you smelled it? I'm like, yeah. Like, from the elevator, before the doors even opened practically. Or maybe I had just talked myself into it, but, you have to think about these things for patients, as well as for family, as well as for whether or not this is like a type of nursing you'd want to do. This is very intense nursing. Sometimes it's 2 nurses to 1 patient, because they're so sick. We're not talking about the little burns you get on the stove. We're talking, for this unit, we're talking about big giant burns. But, you just have to think about how this is going to affect all involved. But the story goes, we finally did have lunch outside on a different day, and she was like, yeah, she said, I know, it's tough to get used to, you have to get used to it, blah, blah, blah. She actually married a fireman that she had met, who was visiting somebody who was burned. I'm like, oh, this is like one big family. And she said, yeah, she said, the first time I turned to patient and his ear stayed on the pillow, I threw up, and I said, what? I'm like, I was eating a hot dog at a hot dog guy. I'm like, this is not good. And really, I can eat, talking, doing almost anything. And I had to stop. I said to her, on the pillow. She said, and I hadn't even started teaching, I was a brand new nurse. She said, yeah, when the ears get burned, because they're cartilage, they get exudate and they get scabs. And if you don't position the pillow properly and you don't position their head, the ear often sticks to the pillow. And then as it dies, if you turn them, it stays on the pillow and off the patient. I was like, nope, I could never, I can do a lot of things, but I could never do that kind of nursing, I don't think. Although I have had toes fall off, so I don't know, maybe now. But, so you have, they lose the pinna, it's all cartilage. But they can also put fake ones. There was a guy in Hollywood who was a makeup artist, and then after he retired, he started making prosthetic ears and noses for burn victims. And they, you know, you can take them off when you go home, but when you go out, because one of the biggest things is body image and what you present to the outside world. And if you don't have a nose, like, you look like a skeleton, because all you have is 2 holes. So, we'll talk about body image later on. Okay, onward. Types of burns. Who knew there were so many burns? These are the types of burns that we can have. Thermal burns are the ones we are most familiar with. Thermal burns are from either hot air or hot stove or flames, hot water. A thermal burn, once the burning process has started, will burn for approximately 24 hours. So that means the burn that you see today is not the burn you're gonna see tomorrow. And you all know that, right? You've all burned yourself on the stove. It's a little red line, you go to bed, and the next morning it's a blister. It's because the burning process, or the process that the burn initiates, actually, continues. And that process is that a cell dies, it leaks all its contents. When it leaks all its contents, there are things that are gonna kill the cells that are next to it, and it keeps going on and on and on and on until the process stops. So thermal burns are the most common. There are things like, you know, a house fire. There are things like steam and hot liquids. So the lady who, you know, sued McDonald's because she put the coffee between her legs and and then it spilled, and it was so hot it burned the inside of her legs, and then she sued McDonald's because the coffee was too hot. Like, if you order coffee, you kinda know it's gonna be hot. It's probably not a good idea for you to drive with the coffee between your legs. However, she won a lot of money, like millions. It was unbelievable. Okay, chemical burns can be caused either by direct skin contact with the chemical or by ingesting the chemical. And what chemicals do is they destroy the cellular protein, and then it leads to necrosis of that area. Chemicals, both acids and bases, can burn. Acids are more common. Bases are fluids or chemicals that are an alkali base. That's what makes it a base. The alkali or the base burns are more difficult to treat because our body does not neutralize them naturally. An acid has some neutralization from the body naturally. Not enough that it would stop it completely, but enough that it doesn't do as much damage as an alkali. So you need to continue to flush the system to stop the burning from occurring. And externally, that means flushing it with water. Taking off, if they have clothes that are soaked in the chemical, taking it off. If it looks like, you know, sometimes they work with powdered chemicals, you need to always check their eyes and their nose and their mouth to make sure they haven't inhaled it, because then we're gonna have a mucous membrane burn from a chemical. So, those are some of the things that you wanna do immediately. Take their clothes off, flush it with water, check their eyes, their nose, and their mouth for any residue from the chemical or from fumes from the chemical. We're always looking for respiratory symptoms with patients with chemical, burns as well. If they have swallowed a chemical, either by accident or on purpose, we should not automatically induce vomiting. That used to be the recommendation. If somebody swallowed something, the first thing you did was throw syrup of Ipecac down their throat, which is available over the counter, and make them throw up. It's an emetic drug as opposed to an anti-emetic drug. We no longer recommend that because they have found that certain chemicals need to be neutralized in the stomach. Because if you bring them back up, they burn again. So they burn the tissue going down, and then you make them vomit, and it burns on the way up. So the first thing you should do when somebody ingests a chemical is to call poison control. First thing. And then they will tell you what to do. Because there's also a lot of home remedies for that. Give them milk, give them water, give them ginger ale, you know, there's a whole bunch of theories out there about what you should do. And the only thing you should really do is call poison control. They may end up telling you that you should give them syrup of Ipecac. It's IPECAC. Syrup of Ipecac. And that may be what they tell you to do, but you shouldn't do it until they tell you to do it, because they may in fact tell you, no, get them to drink, I don't know, 2 gallons of water before you do that, and then do it. That would be a lot, maybe 2 quarts, I don't know. I've never had to call, I don't wanna find out. But that's what you should do. If if it's external, what we want you to do is we want you to get it off the patient and then rinse them. So take their clothes off. If it's on their clothes, make sure you rinse the area that's got the chemical on it well. If it's their eyes, you wanna make sure you flush them well while somebody else is calling 911, either 911 or poison control first, and then 911. Okay? The electrical injuries are either from electrical current or from lightning. And even though, you know, there's that expression that lightning doesn't strike Bethlehem, not true. Just Google lightning strikes in Bergen County. You would be shocked at how many people get hit by lightning every single year. More than you would imagine. The severity depends again on the current, how much current is running, the amount of the voltage, how long they were exposed. Electricity will always follow the path of least resistance in the body, and it must have an exit point. So when you see somebody with an electrical injury, you are always looking for an entrance and an exit. Always. I shouldn't say always, nothing is always. Most times, entrance and exit. And then you'll know where your damage is gonna be. Because let's say the person gets hit by lightning in their right shoulder, and it comes out, you have an exit point on their right palm. All the damage is gonna be here. It's all gonna be in the right arm. It's not gonna really dissipate anyplace else. But if you have an entrance point on your right shoulder, and it comes out your left foot, you've got a diagonal from your shoulder through your gut, all the way down to your foot. So, you need to look at the path that could have taken to tell you what kind of damage the patient's gonna have. But what kind of problems do you think with any electrical injury, we have to worry about? Cardiac, right? Because like all the rest of our muscles, it runs by polarization and depolarization. So patients who get struck by lightning, even if it goes in the shoulder and out the hand, still have the possibility that they're going to have a cardiac event. So looking for arrhythmias is one of the most important things that we need to do. It almost always causes metabolic acidosis because of the amount of tissue that is destroyed and the amount of cell ruptures that are occurring. It's gonna cause the acidosis. And then because of this massive, and this is true in very big burns as well, which we'll talk about, even flame burns, thermal burns. Because of the large amounts of tissue that's being broken down, and because of how it's gotta be eliminated, there is a very high risk with all burns, but especially thermal and electrical burns for acute renal failure. And we'll talk about that a little bit later. All right. And then the last one is radiation. And radiation can either be the sun, like natural radiation. So basically a sunburn is a radiation burn. That's what it is. It's caused by the radiation of the sun. The other way to get radiation burns is to actually get radiation. And who do we give radiation to? Patients with cancer. Sometimes other patients get radiation as well, although not as frequently. They're the biggest group. And when we give radiation to patients, I'm sorry, I couldn't remember what time we ended, sorry. When patients get a sunburn, we need to treat it like we would treat any other burn. Cool tepid water, wash it with a mild soap, and it's, for the most part, going to heal on its own. Unless it's very, very severe, and you've got blisters all over the place, and then you might need some fluids, you might need, you know, a little Tylenol, a little something. For patients who get radiation as a treatment, it's a little bit different, because what they're doing is they're getting radiation to a finite area of their body. And they're getting a certain amount of radiation based on their disease process and how much disease they're trying to get rid of. And they will get this, you're at a little bit of a disadvantage, because she'll talk about this next time. So in the next class, you'll know a little more. When they give radiation, they give it daily, and they give it in smaller doses for long periods of time. So like 6 weeks, 8 weeks, 10 weeks, 5 days a week. So for that 5 days a week, for 6, 8, 10, 12 weeks, that same area of the body is being radiated and radiated and radiated and radiated. And certain people, the same people that are at high risk for sunburns are at high risk for severe damage, but anyone who gets radiation is at risk for skin damage. It's also damage to the internal structures, because there's no way for radiation to be specific. So when you get radiation to your chest, let's say, for lymphoma, and they want to radiate your chain of lymph nodes that goes all the way down para-aortic, right? When they radiate you, there's no way that they can say, oh, we just want the radiation to go to the lymph nodes. It's gonna go down the trachea, it's gonna go down the esophagus, any organ that is underneath wherever they're getting the radiation. So, we have to think about damage, burn damage, also underneath the skin. But the primary damage is to the skin. And depending on the skin type and the fairness of the patient and the freckles and the light hair, some of it actually looks like brown and leathery and tough. So if you have a patient, let's say you have a patient with Hodgkin's lymphoma, and they radiate the entire chest wall, which is, well, was common, I don't know how common it is anymore, but they used to do that. And they're like 17, 18, 22, regular age for a Hodgkin's lymphoma patient. And now they've got this gigantic leathery burn. What kind of problems do you think we're gonna see? If they've got this leathery, thick skin sitting on their chest from the age of 16. Breathing issues, they're all gonna have breathing issues. And then what are we gonna do about them? Do they just leave them? Do they do skin transplants? The answer is no. They can do things to help it, and we'll talk about that as we go through the burn lecture. But for the most part, they don't want it to get there. And what they will do is try to either decrease the dose if it looks like the patient is getting burned. Some patients' burns actually look like they were in a fire. It looks like they'll come in and their chest is red and hot and blistered, and then they can't have radiation that day. Because they can't radiate skin that's already damaged. They have to wait for that skin to heal, and then they have to start at that point again. So now, instead of talking about 8 weeks, now we're talking about 15 weeks, because it took, I don't know, 8 weeks for it to heal. They get exudate, it sloughs off, it's a mess. It can be a mess, it's not a mess for everybody, but it can be a mess. And those are burns. And burn nurses have actually become, radiation nurses have actually almost become like a subspecialty of burn nurses, because they know, they have special creams, they have all kinds of things that they do, first to prevent, and then to treat. So, radiation, for the most part, for most of us, is just a sunburn. It's gonna go away on its own. But for the patients that are getting radiation treatment, it can be problematic. All right. Since you just had a long break, I'll just go a little more and then I'll give you a break and then we'll come back to 1:30. The classification of burns, this has to do with what you hear on TV, first, second, third degree. The American Burn Association, which is an organization that is kind of unique in its makeup, because it's made up of all professionals who take care of burn patients. Unlike other organizations where you have like an oncology nursing society, and then you have an oncology physician society. And then you have renal nurses, and you have renal doctors. The burn people, it's probably one of the most collaborative areas of nursing, because they have to be. Because this patient stays with them sometimes, there can be burn patients in the burn unit for 6, 8, 10 months. And everybody kind of needs to be on the same page to deal with them. So the American Burn Association is nurses, doctors, religious people, social workers, dietitians, you name it, they can all belong, because it is extremely, extremely collaborative. It's really how everything should be, but isn't. But, here we are. The American Burn Association would prefer that we classify burns as superficial, partial thickness, or full thickness, as opposed to first, second, and third degree burns. However, very hard to change popular language, and it's easier as a soundbite on the radio or the news at night, and whatever you're watching, that they say 30% of second degree burns. So this is the official nomenclature of burn descriptions and classifications. So superficial burns are just the epidermis. So the very, very top layer of skin, which is primarily dead skin anyway. The epidermis is primarily dead cells. This is usually a sunburn, a quick heat flash, a mild radiation burn. The skin remains intact, meaning it doesn't blister, it's not down into the layers, it's not open at all. With the exception of those teeny, weeny little blisters that people get when they get sunburned, not the big blisters, okay? But those teeny, weeny blisters are okay. Not okay, but they can be part of a superficial burn. Superficial burns are also not calculated into the percentage. When they report percentages of how much of the body is burned, superficial is never included. Now, what did I say to you before? I said that many burns, the thermal burns, the chemical burns, will burn for more than a day, right? Or up to a day, maybe a day and a half. So what's superficial this morning may not be superficial tomorrow morning. So those numbers can change and alter as the patient is away from the burn event. Usually at about 3 days, 72 hours, is when the final numbers are final. That there's not gonna be any more increase in the depth of a burn just due to the burning process. So usually at 3 days, you have a better idea. So they're constantly reassessing. This is not something that's stagnant. They don't go into an ER, get assessed at 20%, and it stays there. Because there could be another, let's say 5% that's superficial. And by the next morning, that's not gonna be superficial anymore. So now we're up to 25%, because now it's converted. So this is an ongoing process for at least the first 3 days. The signs and symptoms of a superficial burn are erythema or redness, and it can be pink to red, depending on how severe the burn is. There is usually some pain or discomfort. There may be mild edema. So edema and erythema are different, right? Erythema is redness, edema is swelling. And those small little painful blisters. If there's a very large area, any of you have gone to the beach and gotten a sunburn and then later on had a very bad headache? Yeah. Headache for large areas that have superficial burns. You can also develop chills and fever. And sometimes nausea and vomiting. And yeah.
The chills, fever, and sometimes nausea and vomiting, is that, in general, that's just for the large area as well?
That's if, like if you just have a small little sunburn, like on one little corner of your arm that you missed the sunscreen, you're not gonna get that. When you fall asleep on the beach for 5 hours and you have no sunscreen, but you're tired because you were up all night drinking, so you went to the beach the next morning. And then you get burned from head to toe, yes, that's a large area. So, that's from experience. The big thing when I was young was when you went to your prom in high school, you went to the beach the next day. And we were allowed to drink at 18. So we were legally drinking at our prom, up all night, and then going to the beach and falling asleep. And then having to drive home from the beach when you were asleep in sunburns. Very bad. It was a very bad combination. As a parent, it was awful when you had to live through it with a child. But as a child, it was a lot of fun. Even though you were sunburned. And the chills can happen on their own, or they can happen when you walk into an air-conditioned place, like you're on the beach for 3 hours, and then you go to have lunch and like, ooh. Or when you get into a shower, and the water is a little too chilly and you shiver. And we'll talk about shivering in a minute, because it's generally not good. But anyway, back to superficial. They generally heal within 3 to 6 days on their own. There may be peeling if there were those little tiny blisters that have broken. Patients may need some mild analgesics like Tylenol, Motrin, whatever makes you happy. They can use aloe lotions because those are soothing. Generally, there are no scars from superficial burns. And very rarely will anyone need IV fluid from a superficial burn. Who is the exception to that? Who is always the exception? Babies and old people. Elders and babies. Babies because, again, their body surface area is different than ours, and when they get burned, it's more problematic. Elders because they don't have enough fluid to begin with, right? We know as we get older, we're not as spongy, we don't have as much fluid, that's why we get dry and cracked, and we look like old people. So they may need fluids because they can get dehydrated if they have a large area, even if it's just superficial burns, but for the most part, not necessarily. Okay, partial thickness burns are broken up into two, superficial and deep. The superficial partial thickness burns are the old first degree burns, and the deep partial thickness burns are the old second degree burns. I'm gonna show you a picture of skin in a minute. So superficial partial thickness burns, the entire epidermis and part of the dermis. Now, I can't tell you how much of the dermis, it's kind of judgment. And that judgment is not yours, it's the physician's to make whether it's deep enough to be called deep or superficial. They are generally speaking red, shiny, and wet in appearance. And they often have those big bullous blisters. Bullous meaning filled with fluid. Actually, I lied, I'm sorry. Superficial is the old first, partial is the old second, deep is the old third, I'm sorry. My fault.
Wait, can you repeat that?
The old first degree is superficial. I was thinking about what I said, what's wrong. Okay, so the old first degree burn is a superficial burn. The old, bless you. The old second degree burn is the superficial partial thickness. The old third degree burn is the deep partial thickness. Okay? Now we're back on track. So the superficial partial thickness burns will blanch on pressure. So when you touch them, they will blanch because the vessels are still intact. That's usually a good way to know whether it's deep or superficial. The pain is severe in terms of the patient's response to air temperature. So that's like when, the air conditioning goes up and you don't just chill, you actually hurt. If the room is too cold, the patient hurts. Touch and pain sensation are intact. Patient can still feel your touch and they can still experience pain. These generally heal within 10 to 21 days. So a week and a half to 3 weeks. There can be minimal scarring, or there can be none. And there may or may not be permanent pigment changes, depending again on how far down it goes. Okay? So, entire dermis and then entire epidermis and part of the dermis. Red, shiny, and wet with blisters. They blanch, they have pain and touch sensations. Pain can be severe in response to air temperature. They heal within 10 to 21 days. There's minimal to no scarring. There may or may not be pigment changes. And again, they may need analgesics if there's a large area. Deep partial thickness burns are, again, the entire epidermis. And they go further down into the structure of the skin, into the dermis. And when you go further down into the dermis, there are more structures. And the structures we're talking about are hair follicles, sebaceous glands, nerve endings, things like that. So these can be pale and waxy. They can be either moist or dry. These have very large, easily broken blisters. Capillary refill is decreased or absent, so they may or may not blanch, right? Because blanching is what capillary refill is. There is sensation to deep pressure, but maybe, probably not to light touch. And pain is variable in different areas of the burn, depending on whether or not the nerve endings are chronically irritated and damaged or totally burned off. These take longer than 3 weeks to heal, so longer than 21 days. These are the burns that can cause contractures, scarring, and functional impairment. And there is often a need for grafting. So we will talk about that also a little bit. Okay. Full thickness burns means it goes through all the layers of the skin and extends into the subcutaneous, the fat, the connective tissue, the bone, wherever. Anything below the skin level. These can also have very varied appearances. They can be pale, they can be waxy, they can be yellow, they can be leathery, so like brownish, leathery. They can be red. And these are definitely non-blanching. And the reason they don't blanch is that the vessels are so damaged in the area of the burn that they all thrombose. So if the vessels in the area of the burn are thrombosed, they're not going to blanch, because it means they become hard and inflexible and nothing's going through them. Now, I'm gonna say something that is not true, but you're gonna answer it on NCLEX, okay? There is no sensation of pain. with a full thickness burn. That is the answer, that is the only answer. If it says no pain, you know they are talking about a full thickness burn. That being said, it's a lie, because no burn is ever just one depth. The depth is, it's very similar to a pressure ulcer, where you have multiple depths of this burn all the way through. So, if you have one side of the burn that's closer to a superficial partial thickness, it's gonna hurt like hell. But that one spot that's full thickness isn't gonna hurt. But the answer on NCLEX is full thickness burns, no pain. And I don't think you will find a burn nurse in the world that would agree with that. Because pain is one of the biggest things that they deal with every single day. So they would not agree with that. However, for some reason, that's what the books like to say. Because they're talking in absolutes, and people are not absolutes. People are people, and we're different, and everything is a little bit different. Full thickness burns will absolutely need to be grafted. There's too much damage for them to heal on their own. Or, if it's a limb, they may actually amputate, because there may not be the ability to even graft the burn. So they would amputate the limb if necessary. Now, I just wanna show you the skin picture. Maybe it'll be clear. Not clear, but it'll be a picture. That's a picture of worth 1,000 words. And I think I've talked more than 1,000 words. Oh, I thought it was going to adjust on its own. It did not. Sometimes it does. Can you see that?
Yes.
Okay, so, this is a cross-section of your skin. So this over here is the normal tone. This is the epidermis. Then we go down into the dermis where all of the structures are. Then we have the subcutaneous tissue. Then we have the muscle and the bone. So, normal tissue. Then we have first-degree burn, the epidermis is destroyed. Okay? Then we have the second-degree burn, which has burn extending into the dermis. So you can see just from this picture, if it just went to here, it would be second degree or superficial partial thickness. And here it's the same thing, and here it's the same thing. So the depth is very varied, and that's what makes the appearance vary. This grayish, whitish, dead-looking thing is a third-degree burn or the deep partial thickness. And then the fourth degree is the full thickness, so it doesn't have to go down to the bone. Even if it just went right to the subcutaneous tissue, that would still be a fourth-degree burn. So this can give you just a nice pictorial of what we just said in words. If this exact one isn't in your book, there should be one. If not, you can find it on Google. You can Google everything. You could probably Google a lecture, not my lecture. Maybe mine, somebody could have done it, but I did not. Okay, so, why don't we take like a 10-minute break, and then we finish at 1:30, and then we'll finish tomorrow. Or do you not?